Hi, welcome to another episode of Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzal.
In today's episode, we're going to be talking about something that's very common throughout North America and the rest of the world, and we're going to be talking about hip fractures.
Yes, very common, but it can be a big burden on the patient, their family, on everyone.
Yeah, the hospital system for sure, and becoming more common as people age and live much further into life.
Yes.
Paul, I always think about hip fractures really related to two separate groups of people. One is the significant trauma group, so often the younger people, car accidents, severe falls, and then the older populations that are tripping on a carpet and falling from a standing height and breaking their hip.
Yes, way more common, I would say the latter.
Yes.
But yeah, two definitely different populations.
Do you, when you talk to people in the office about this happening, are there specific risk factors that you worry about for someone that's going to have a broken hip?
Sure. There are risk factors for a broken. Probably the biggest risk factor is osteoporosis. If you have osteoporosis, you have an increased risk of fracturing your hip with less trauma.
I would agree. And then probably the general medical risk of falling. So if you had a balance issue, if you had a difficult vision, if you had too many rugs on the floor, if you took medication that inhibited your balance.
Yeah. So yeah, the best advice would be if you're planning to break your hip, don't. So
That's
if you can,
solid advice.
if you can prevent it, so make sure, especially if you are elderly and living alone, you don't want to have a lot of rugs on the ground, carpets or uneven ground. Try and make your environment as safe as possible.
And a lot of hospitals actually have a falls prevention program. I know
Yes.
our hospital does, and it's invaluable.
Yeah. And then where we live, there is a lot of ice outside often, and that can be very dangerous. So if you use a cane, spikes on the end of your cane or spikes on the bottom of your shoes, good shoes with good treads, whatever it takes, try and avoid.
Spikes on the bottom of your shoe, really?
Yeah, you can get these, like they strap on, they're spiked.
Cool.
I'm wearing them right now.
Okay. Signs and symptoms of a broken hip. You fall and you're like, I don't know if I broke my hip. How do I know?
Okay, so the first symptom would be pain, a lot of pain. Which leads into an inability to weight bear. So
Yep.
you fall and you can't put weight on it, you have a lot of pain. And you might even notice that your leg isn't lined up like it was 30 seconds ago before you fell.
Is the pain on the side of your hip?
Some people do have some pain on the side, but most commonly you feel a hip pain in the groin.
Okay.
That would be the most likely, most common place to feel hip pathology, such as a fracture.
All right, so if you can't get up, you call 911 or you call the phone or someone helps you out. You get to the hospital and the doctor there sees you, and how does he diagnose it?
So we always do a full history and physical examination. So we ask you what happened and take a full history and a full physical examination. And on examination, the physician will find that anytime he tries to move that leg, your hip hurts. Your leg looks maybe short and externally rotated, and then X-rays. Ultimately, the diagnosis is made on X-rays. On the rare occasion when an X-ray can't see the fracture, a CT or an MRI may be done, but usually the vast majority of the time, an X-ray diagnoses the hip fracture.
Okay, are all hip fractures the same?
Yes, that's a good question.
Yeah, they are?
No,
Oh,
not.
Okay. Okay.
They're not at all. Let's run through quickly the anatomy.
Okay. So this is a right hip. So this is part of your pelvis. We're missing the left half. This is your right hip. Your right hip is made up of a ball and a socket commonly. It's a relatively simple joint, and the socket is part of what's called your acetabulum, or joints to your pelvis, and then the ball.
It's hard to dislocate a hip.
It is hard to dislocate, even in a model. This is part of your femur, or your proximal femur that makes up your hip joint. This is the ball that we were talking about. This ball is covered with cartilage. As this cartilage wears away, this is what causes hip arthritis and ultimately leads to a hip replacement.
Well, that's another video.
Another video. Certainly you can watch it on our series. There are probably two main places, well, I'd say three main places where your proximal femur or your hip can be broken. One is just below the ball. We call that a femoral neck fracture. So when the ball breaks, that's one type of fracture. The other one is called an intertrochanteric fracture, where the fracture line goes between what's called your greater trochanter and your lesser trochanter. It's an oblique line down this way. And then the last one is more of a femur fracture than a hip fracture. It's called a subtrochanteric femur fracture, and it's actually down below your lesser trochanter, which also has a very specific kind of treatment. That's a lot of information, but it's important for the types of surgeries that they require.
So you've probably guessed the majority of the time when you break your hip, it happens on the femoral side or on the femur. Very occasionally, when you break your hip, you fracture on the socket side. This is very rare. This is more common in younger people, high trauma, to break the hip in this area, and we now refer to this as a pelvic fracture. If you break the socket, it's more commonly referred to as a pelvic fracture. But when you're talking about a hip fracture, it's breaking your proximal femur.
Now, the treatment for all fractures is typically broken down into operative and non-operative treatment, and we've talked about this in other videos. We'll just really quickly talk about non-operative treatment of hip fracture. Paul, do you ever implement this type of treatment?
Yeah, so non-operative treatment of hip fracture. If you have a fracture that is completely undisplaced or very stable and nothing has shifted out of position, that can be treated with protected weight bearing, just crutches and non-weight bearing, or a walker and non-weight bearing. But that is extremely rare. I've seen this, maybe once every 3 years, for example. So that would be like a non-operative treatment for a hip fracture. Or if you have a hip fracture, however, you're near the end of your life. So you're probably not watching this video.
You're probably not watching the video.
Probably a family member.
I'll just say your family members are going to be watching the video.
Yeah. So if your relative, mother, father, grandmother, grandfather, is near the end of their life and they have a hip fracture, so they have other medical conditions, then to me it does not make sense to go in and try and fix this fracture if the person is going to pass away within the next few days. So those are probably the main times when I don't operate on hip fractures. Other than that, a hip fracture almost guarantees surgery.
I would totally agree. And that's a decision made by a lot of people, the family members, the patient or their advance directive, as well as the healthcare team that's involved. So deal with that on a case-by-case basis. So when it comes to surgery, there's only one surgery for all hip fractures, Paul?
No. So as Brad alluded to, there are lots of different types of hip fractures, depending on where you break your hip. The neck, at the intertrochanteric region or below the trochanter, and where the fracture occurs is one of the most important factors that help us decide what type of surgery to do. And the options for surgery are half a hip replacement, a total hip replacement, or some sort of fixation, such as a plate and screws or a rod inside the femur.
And even one other one that we had talked before is potentially just 3 screws.
Or just 3 screws.
Or 2, I guess.
Yeah. So those are really your options. So basically, when you look at surgery, you look at, am I going to do some form of replacement, or am I going to try and fix the fracture? If I'm going to try and fix the fracture, am I going to use a plate and screws, a rod, or just screws?
And we'll get into details of the procedures in other videos, but just the real short version is that fractures that are higher up or closer to the ball typically lend themselves to replacement because of the nature of the blood supply to the ball. And if the fracture goes down further, we typically replace those fractures. There are lots of variables involved, but that's kind of
those fractures.
Yeah, we fix them.
Okay. So that's basically it. Like other fracture videos you might have seen, non-operative treatment takes a big role. In hip fractures, non-operative treatment is a very small role. Surgery is by far the most common way to treat a hip fracture. So I've broken my hip, or a family member has broken their hip. They've seen the surgeon. The decision has been made on what type of surgery to do.
Yep.
Had my surgery.
Yep.
Now what?
So you're back in the hospital, or you remain in the hospital, typically for about a week. That's very variable. Our goal after hip fracture surgery is to try to get the patient back to their pre-fracture ambulatory status. So if grandma walked a block before with a walker, that would be our goal. Often they don't quite get there, but that's our goal. So with surgery, the whole purpose of it is that we're not going to have you lying in bed, putting you at risk of things like a blood clot or an ulcer or aspiration pneumonia. We want to get you sitting up and taking steps as soon as possible with as much of your own weight as possible on that leg, depending on the success of the fixation.
Right. Years ago, not that long ago, even when I was training, after we'd fix a hip fracture or even replace a hip, we would not let people walk on that leg for 6 weeks. However, there are a lot of risks associated with being non-weight bearing, such as blood clots, pneumonia, just general deconditioning. So now, my goal, and I know Dr. Wiening's the same, in the operating room, we try and get your hip fixed in such a way that we can let you walk on it right away. You may not be able to walk on it right away because of pain and weakness from surgery and injury, but we try and make the fixation or the replacement such that you can walk on it right away to get you moving as quickly as possible, because that is the goal, to get you back moving as quickly as possible.
And usually that's done with the assistance and guidance of a physiotherapist, most typically with a walker, at least for the first couple of weeks, so that you can be stable and reduce your risk of a further fall depending on the initial cause.
Right. So you broke your hip, you had surgery, you've been in the hospital for about a week, you're allowed to walk on it, and you've had help with a physiotherapist to teach you how to walk. An occupational therapist now comes along and says, okay, let's see what your living environment is like, and let's see if you are safe to go back to that living environment.
Yeah, so often that is a huge challenge as people age and may have been living independently, and then they break their hip, and then they can get up and walk around with a walker, but clearly can't go home to live on their own. So our social work team and the occupational therapist and a discharge planner are involved to say, can we send you back to your own apartment? Do you need to go to convalescent care potentially? Do you need inpatient rehab? Or maybe we have to start thinking about placement in a nursing home or a retirement home where there's some greater supervision. And that's a family decision, obviously.
Right. So in very elderly patients, I find that they sort of lose a level of independence after a hip fracture. That's very common.
Yeah. And it's disappointing and it's sad, certainly, for the family. But often those cases have almost been declaring themselves a little bit already, and the son or daughter comes in and says, yeah, mom or dad was having a little bit of trouble. They've had 3 or 4 falls already. They maybe didn't break their hip, but they hit their eye or cut their head or something. And often a hip fracture is really revealing that there's maybe some bigger medical problems going on, because it's a big deal. I think often because we do so much surgery, everyone thinks, oh, it's a hip fracture, we'll just fix it, they'll be fine. I think it's important for families to recognize that this is a really big deal and has really significant longer-term risks. Why don't you talk about that, Paul?
Long-term risks, sure. So, I mean, long-term risks probably more relevant in a younger patient with a hip fracture, but also things we worry about with elderly people with hip fracture. So I think right off the bat, we should just put on the table that there is a high mortality rate associated with hip fracture in elderly people. It can be as high as 50%. If someone in their 90s breaks their hip, the 1-year mortality, so the chance of dying within 1 year, can be as high as 50%. Certainly in a young person who breaks their hip, the mortality is much lower, and that's usually associated with a higher trauma, ironically. But certainly in elderly people, it's not because of the hip fracture, it's just an association that an elderly person with a hip fracture has a significant mortality rate.
And I think people don't appreciate that, because in practice, very rarely does someone not get through the operation. We can get almost anyone through surgery with the advances in medicine and anesthesia and surgery. We can get almost anyone through surgery. So then you talk to the family, say surgery went well, and then grandma's sitting up in a chair, and then 3 months later she has a fetal heart attack or a blood clot. Right. They wonder why that happens, but unfortunately it's common.
Yeah, so the 1-year mortality can be high. So aside from that, risks of fracture. If you've had a hip fracture and you've had a hip replacement of some form, if you had a half a hip replacement, down the road you might need to have that converted to a total hip replacement. If you've had a total hip replacement, down the road you may wear out that total hip replacement and need a revision. If you've had your fracture fixed, there is a chance that it doesn't heal and you need more surgery down the road, there's a chance that it heals and you develop arthritis in your hip.
Post-traumatic arthritis.
We've talked about that before. Whenever you break a bone at or near a joint, you're at risk for developing post-traumatic osteoarthritis. If you develop arthritis in that joint, in your hip, then you may need a hip replacement or something, or you may opt to have a hip replacement or something like that down the road. And then, of course, anytime you have hip surgery, there's always risks associated with it. What's your speech for hip fracture risks?
So I tell anyone that's having any type of anesthetic, there's a risk of serious things, including infection, blood clot, heart attack, stroke, and death. Specific to a hip, I would say the risks are risk of dislocation, risk of non-union or delayed union. Right. Pain, stiffness.
And the other thing I tell people is leg length discrepancy.
Yes.
Because you may have lost a bit of bone with the fracture, or if you've had your hip replaced, there's a chance that your leg will not be the exact same length it was after the fracture heals or after you've had your treatment. It may not have the exact same length that it did before, so you may notice a leg length discrepancy, and you may even choose to use a shoe lift in one side or the other after.
One other just quick aside about older people having surgeries, that the other thing I also tell them is, depending on the type of anesthetic, there's a risk of having post-operative delirium or confusion. If the patient is a little bit confused before and they have an anesthetic, that delirium could be increased either temporarily or permanently. That's why our preference is for a spinal anesthetic where there's a needle in your back and it frees your legs, but sometimes that's not possible and patients have to go to sleep. And in that setting, as well as with medications afterwards, people can be confused, and sometimes that doesn't come back. And I think that's often, it's difficult for the patient, but it's very difficult on the families, and it's easier sometimes if you're prepared for that.
Right. Agree. Good point.
I think that just about covers it, Paul.
Yeah. Yeah, of course, if you have any questions.
Please email talkingwithdocs@gmail.com.
And remember, you are in charge of your own health.
See you next time.